Today we will be offering a webinar, which is a review from our 25th Biennial Conference on the diagnostic and therapeutic approaches to vulvodynia by the wonderful, esteemed Dr. Haefner from the University of Michigan.
This is a lecture on vulvodynia. We'll be exploring how to evaluate the patient, how to diagnose vulvodynia, and what are some of the etiologies of vulvodynia. I'm Haefner. I'm at Michigan Medicine in Ann Arbor, Michigan. I do have a disclosure. I am an author on Up to Date. The learning objectives for this presentation. I'd like you to become familiar with patient evaluation and making the diagnosis of vulvodynia. We're going to have you understand the current classification system for vulvar pain developed in 2015 and explore the various causes of vulvodynia. This is a publication from 2019 by Bornstein et al. It was a letter to the editor entitled Vulvodynia, a Neglected Chronic Pain Diagnosis. In an earlier edition of the journal Pain, the International Association for the Study of Pain developed a chronic pain classification. However, vulvodynia was not mentioned in the above classification. It's forgotten by many specialties. What is the prevalence of vulvodynia? Barb Reed and other co-workers at Michigan Medicine did a study published in 2011 where we found 8.3% of women in our southeast Michigan area had vulvodynia. A similar study by Bernie Harlow and co-workers found a 7 to 8% prevalence in Boston and Minneapolis. There's other vulvar pain assessment questionnaires in the literature. This was a study by Dargy et al. That looked at the vulvar pain assessment questionnaire. It's a tool that helps clinicians with an accurate assessment, conceptualization, and diagnosis of chronic vulvar pain. In addition, this tool seemed to give women a voice to describe the impact these pain conditions have on their physical, mental, and sexual well-being. The VPAQ is a descriptive question analysis about pain characteristics. It takes about 20 to 25 minutes. There's also 3 supplemental scales that take 10 minutes. And below you'll see the website that it's available at. In this study, the VPAQ screen was more than 80% accurate in predicting the diagnosis of vulvodynia in a specialty clinic. It was useful in assisting patients with expressing their symptoms. The evaluation and diagnosis of vulvodynia is generally made with a thorough history and a cotton swab. The cotton swab test is used by starting on the lateral thighs, going to the labia majora, the interlabial sulci, the labia minora, etc., and ending on the vestibule, and having the patient categorize the quantity of pain that they have in each location that is touched. Generally, there's no need for a vulvoscope in this condition. So here's a diagram of the cotton swab test. It shows you Hart's line, and between Hart's line and the hymen is the vestibule. Many of our patients have localized pain to the vestibule, also known as vestibulodynia or localized vulvodynia. This is an example of what generalized vulvodynia repair is. It's on the labia majora, the interlabial sulci, the labia minora, and the vestibule, as compared to the localized, which can be localized to the clitoris or, as I mentioned earlier, the vestibule. Interestingly, unilateral vulvodynia is also a localized vulvodynia. I have to be honest with you though, not all authors are in agreement with the cotton swab test, and I'm actually one of the authors on this study. Barb Reed and others published in 2016, Does Degree of Vulvar Sensitivity Predict Vulvodynia Characteristics and Prognosis? This study showed that women with vulvodynia had more vulvar sensitivity than control women, but the spectrum of sensitivity was broad. Furthermore, those with and without vulvar sensitivity did not differ in most vulvar pain characteristics or in prognosis. This suggested that a positive swab test is not required to substantiate the diagnosis. In 2019, Bornstein et al. Published a study. They looked at the definitions of vulvodynia descriptors amongst 3 societies, the ISSVD, ISSVD, and the IPPS. They recommended that their definitions of vulvodynia descriptors, as well as the 2015 consensus terminology, be used for the classification of vulvodynia in patient care and research. This table talks about the definitions, whether it's localized, generalized, the onset, whether it's primary or secondary, and the temporal pattern. Let's now go ahead and explore the etiologies of vulvodynia. I've done a recent literature review, and first I have an apology. If I left your article out of this lecture, please forgive me. I also have a second apology. If I included your article and you are not happy with what I say about your article, please forgive me. This study by Wesselman et al. Looked at the current state of biological science and vulvodynia. It's an excellent article that goes into significant detail on various items I'll be talking to you about. In the pathophysiology of vulvodynia, there's many things that can go into it. A lot feel that life stressors are involved with vulvodynia. Some feel that hygienic behaviors are involved. Others, it's an environmental exposure problem. While others say it's the microbiome, and that's what's behind the pathophysiology of vulvodynia. I don't think it's one reason. In this study, they looked at multiple things that could be involved with vulvodynia, and their conclusion was that wearing tight-fitting jeans or pants and removing hair from the mons pubis area were associated with an increased odds of vulvodynia. This was published last July 2019. Very few studies have assessed hygienic practices and their relationship to vulvodynia. It's an interesting finding, as many of our patients do wear these tight jeans and many are removing hair from the mons pubis. This study Barb Reed and I worked on, it was entitled Environmental Exposure History and Vulvodynia Risk. It was a population-based study. This preliminary evaluation suggested a positive association between vulvodynia and the reported history of exposures to a number of different household and work-related environmental toxins. Let's move on now to the thought of yeast being behind vulvodynia. Another study by Bernie Harlow and his associates, Recurrent Yeast Infections and Vulvodynia. Can we believe associations based on self-reported data? They looked at recurrent yeast infections and found them to be associated with risk of first-onset vulvodynia. Once women received a diagnosis of vulvodynia, they were more likely to report subsequent recurrent yeast infections. Their conclusions: there appears to be a positive relationship between yeast infections preceding and following the diagnosis of vulvodynia. But this relationship varied from strong to non-existent depending on the relative accuracy of the recalled diagnosis of yeast infections among cases and controls. Another study published the same month in 2020 looked at the characteristics of the vaginal microbiome in women with and without cyclically confirmed vulvodynia. It was a case control study of 234 Minneapolis-St. Paul area women with clinically confirmed vulvodynia and 234 age-matched controls. Their findings were that although there were no overall differences in the microbiome profiles between cases and controls, the vaginal microbiome diversity influenced associations between environmental and psychosocial risk factors and vulvodynia. In April 2015, these societies got together and developed a consensus terminology and classification of persistent vulvar pain. This was supported by ISSVD, the ISSVD, and the International Pelvic Pain Society, along with support from the National Vulvodynia Association. By the end of the meeting, we had come up with a consensus that all of us were able to agree upon. We talked about two conditions of the vulva that had pain. One, vulvar pain associated by a specific disorder, whether it's infectious, inflammatory, neoplastic, etc., where you can see and know what's causing the pain, versus what we're talking about today, vulvodynia, which is vulvar pain of at least 3 months duration without a clear identifiable cause. And then within that category is localized, provoked, onset, and a temporal pattern. The appendix was very important for those of us doing research. This was potential factors associated with vulvodynia, including comorbidities and other pain syndromes, genetics, hormonal factors, inflammation, the musculoskeletal organ system, neurologic mechanisms, psychosocial factors, and finally, structural defects. So let's go through some of these and go into detail on how they may be involved with vulvar pain and what's new in that research area. So what about other pain syndromes? We all hear about interstitial cystitis in vulvodynia, fibromyalgia, irritable bowel syndrome, TMJ, etc. in our patients with vulvodynia. Studies have looked at the embryologic derivation of the bladder and the vestibule from the urogenital sinus and wondered if that could be a reason behind vulvodynia. Ferriello and Moldwin in 2015 published this study. They looked at intertwined perspectives of the embryology, pathology, and epidemiology of these conditions, and they noted that there were similar responses to therapies for these conditions. And we see that in our practice. The patients with IC are getting better on amitriptyline, as some of our vulvodynia patients, etc. One thought on genetics is quite complex. We've all seen patients with candida infections develop vulvodynia, or at least think they have candida infections and say that's when their vulvodynia started. Maybe it has to do with mannose-binding lectin or the NALP3 expressed in macrophages. Or could it be neurotransmitters involved, going on to G protein-coupled receptors, or the cytokines, the interleukins being involved, the microRNA, or Dectin-1, for example. Dectin-1 is a transmembrane protein containing an immunoreceptor tyrosine-based activation like motif in its intracellular tail, and one C-type lectin-like domain in the extracellular region. All of these are fascinating, especially the familiarity going back to genetics. This study, published in 2016 by Morgan et al., is entitled Familiarity Analysis of Provoked Vestibulodynia Treated by Vestibulectomy Supports Genetic Predisposition. This study design used a population-based genealogy linked to the University of Utah Hospital CPT-coded data. They estimated the relative risk of vestibulectomy in female relatives of affected women. This risk was elevated in first-degree, second-degree, and third-degree female relatives. Their conclusion was that vestibulodynia treated by vestibulectomy has a genetic predisposition. They proposed future studies will identify candidate genes by linkage analysis in affected families and sequencing of distantly related probands. What about hormonal factors and vulvodynia? Here's a recent study published in 2020 entitled Expression of Estrogen-Related Receptors in Localized Provoked Vulvodynia. They analyzed protein expression levels of estrogen-related receptors, estrogen receptors, progesterone receptors, and CD3 positive T cells in the vestibules obtained from women suffering from localized provoked vulvodynia and compared them to healthy, unaffected controls. The vestibular tissue specimens were obtained from patients who had undergone modified posterior vestibulectomy. There were 12 of those patients and 15 healthy controls. Their conclusion was that expression of estrogen-related receptor beta was significantly more pronounced in samples of women with localized provoked vulvodynia compared to healthy controls. Another recent study by Mitchell et al. Looked at spironolactone and vestibulodynia. They did a database search of vulvar disorders clinic revealing 7 cases where spironolactone may have caused or contributed to dyspareunia and decreased arousal. In all cases, the patient stopped taking spironolactone and used a compounded estradiol testosterone gel to the vestibule twice daily. Their outcomes were improved sexual function in this patient population. What about inflammation? For years we've argued, is it vestibulitis or not? Most of us feel it should be vestibulodynia, that inflammation as an inflammatory WBC is not behind vestibulodynia. This review summarized the literature regarding the role of inflammation on the genesis of vulvodynia. Some evidence exists for altered histology consisting of increased numbers of mast cells and nerve endings, while others show no association with mast cells. Immunological abnormalities that have been reported include altered cytokines and neurokines. However, thus far, none of the findings have led to adequate treatments. Mast cells, a form of inflammatory cells, have been studied in vestibulodynia. I'll show you 2 studies on this slide, one by Bornstein et al. And one by Rhaegar et al. In 2004, Dr. Bornstein looked at mast cells in 40 patients with vestibulodynia and compared them to normal controls. He found a significant increase in mast cells and degranulated mast cells in the vestibulodynia patients. In the study by Rhaegar, control tissues were obtained from autopsies, although in the paper I was never able to find the number of control tissues obtained. In their study, 20 out of 35 vulvodynia specimens showed a T lymphocyte-dominant inflammatory infiltrate on sections that were stained, but all showed mast cells. 4 out of 35 biopsies showed less than 10 mast cells per millimeter squared. 15 out of 35 specimens had 40 to 60 mast cells per millimeter squared, and 16 out of 35 specimens had over 60 mast cells per millimeter squared. The control tissue contained typically less than 10 mast cells. However, a study by Dr. Papuzza and all that I was involved with, along with Chris Crum, Tony Opapari, and Barb Reed, we published in 2016. We were interested in mast cell density in vulvodynia. It was a case-controlled study. We found no difference in mast cell density in biopsies of the vestibule found between white women and racially matched controls. The black control women had a lower mast cell density compared to white control women. There were 300 patients studied in this vestibular mast cell density study. Looking on to some other pathways, right now marijuana is very popular in Ann Arbor, Michigan, and I found it interesting that Boo et al. Published on tetrahydrocannabinol and found that it reduced hapten-driven mast cell accumulation and persistent tactile sensitivity in the mouse model of allergen-provoked localized vulvodynia. Perhaps marijuana will show to be a treatment for this condition. A significant body of research demonstrates macrophages can contribute to hyperinnervation and nociceptor sensitization in multiple pathological conditions. Studies clearly show macrophages are highly dynamic and can transition between polarization states that have distinct effects on nociception, suggesting that they are a potential target for interventions to modulate pain severity. A study published in 2020, the cutaneous inflammation differentially regulated the expression and function of angiotensin II types 1 and 2 receptors in rat primary sensory neurons. Neuropathic and inflammatory pain results from cellular and molecular changes in dorsal root ganglion neurons were evaluated. The type 2 receptor for angiotensin II has been involved in this type of pain in other studies. A combination of immunohistochemistry and immunocytochemistry was used to examine how cutaneous inflammation affected the expression of AT1R and AT2R in subpopulations of rat neurons and studied their impact on inflammation-induced neuridogenesis. This study, published in 2018 by Falsetta et al., entitled Toll-like receptor signaling contributes to pro-inflammatory mediator production in localized provoked vulvodynia. They found that human vulvar fibroblasts expressed a broad spectrum of toll-like receptor signaling. A significantly higher TLR-mediated pro-inflammatory response was observed in localized provoked vulvodynia case vestibular fibroblasts. We're now going to look at musculoskeletal pain and how it's involved with vulvodynia. Here's a study published in April of 2017 entitled Heightened Pelvic Floor Muscle Tone and Altered Contractility in Women with Provoked Vestibulodynia. They evaluated the passive component of pelvic floor muscle tone in women with provoked vulvodynia. Their findings showed that women with provoked vulvodynia sustained quiescent muscle activity during stretching, still presented with greater passive forces, stiffness, and hysteresis than asymptomatic controls. They concluded that women with provoked vulvodynia showed muscle overactivation as well as persistent alterations in muscle viscoelastic properties. Neurologic mechanisms are also involved with vulvodynia. We've got the central and the peripheral mechanisms. So let's look into what's new in central and peripheral pain processes. Not that 2013 is new, but I wanted to show you this article that we actually published back in 2013 looking at vulvodynia in the brain. We looked at augmented central pain processing in vulvodynia. On MRI, 24 patients with vestibulodynia displayed greater levels of activation during thumb stimulation within the insula, dorsal mid-cingulate, posterior cingulate, and thalamus compared to controls. And this was statistically significant. The augmented brain activation in vestibulodynia patients in response to a stimulus remote from the vulva suggested central neural pathology in this disorder. A more recent study, published in May of 2018, entitled Disease-Related Microstructural Differences in the Brain in Women with Provoked Vestibulodynia, found alterations in microstructure in provoked vulvodynia were observed in the fibers associated with sensory-motor integration and pain processing, which were also associated with increased vaginal muscle tenderness and vulvar pain. These alterations may be contributing to increased pain sensitivity and tenderness, highlighting the need for new therapies targeting the central nervous system. And in this study, altered gray matter volume in sensorimotor and thalamic regions associated with pain and localized provoked vulvodynia was published by Bat et al. In this study, they tested the hypotheses that provoked vulvodynia compared with healthy controls would demonstrate gray matter volume alterations in the regions associated with sensorimotor, cortical thalamic, and basal ganglia circuits. They did structural MRI imaging in 119 premenopausal women. Their findings, compared to healthy controls, were that provoked vulvodynia women exhibited greater gray matter volume in the basal ganglia, hippocampus, and sensorimotor cortices. Compared to patients with irritable bowel syndrome, women with provoked vulvodynia had greater GMV in the hippocampus and sensorimotor network, but lower GMV in the thalamus and precentral gyrus. Well, let's go to the periphery. When we're thinking about the vulva, what is a nerve which supplies the major portion of the vulva? Is it the ilioinguinal nerve, the general femoral nerve, perineal nerve, or the pudendal nerve? The correct answer here is pudendal nerve. The pudendal nerve originates from the S2, 3, and 4 foramina. Another published study from Michigan Medicine in January of 2017 by Reed et al. We looked at women with vulvodynia and we found that they were more sensitive to pressure and to electrical stimuli than were control women. Those patients reporting spontaneous pain versus provoked pain had greater pressure sensitivity to the thumb and greater electrical sensitivity at the introitus, and those with primary versus secondary vulvodynia had substantially greater pressure sensitivity to the thumb. However, we found that having localized versus generalized vulvodynia was not associated with differences in pressure or electrical sensitivity. I mentioned earlier the renin-angiotensin system. I'd like to focus on it now with the sensory axon sprouting for provoked vestibulodynia. This original report was published in 2017. The study provides evidence that local inflammation leads to angiotensin II formation, which acts on the angiotensin II receptor type 2 to induce nociceptor axon sprouting in vulvodynia. They propose that preventing inflammation and blocking AT2 present potential pharmacological strategies to reduce vestibular pain. Falsetta in 2017 published a review of the available clinical therapies for vulvodynia management and new data implicating pro-inflammatory mediators in pain elicitation. They found fibroblasts isolated from the vestibule of patients with localized provoked vulvodynia were sensitive to pro-inflammatory stimuli and copiously produced pain-associated pro-inflammatory mediators, in particular the IL-6 and PGE2. They found that although localized provoked vulvodynia is a multifactorial disorder, understanding vulvar inflammation and targeting the inflammatory response may lead to treatment advances, especially for patients exhibiting signs of inflammation. This study, published in 2018, looked at nerve growth factor and selected cytokines in women with and without vestibulodynia. Women with vulvodynia and asymptomatic controls at 3 offices at Michigan Medicine were examined clinically and completed a comprehensive survey. It was a cross-sectional study. Cytokine-neurokine levels were determined on blood samples using the ELISA protocols. Analysis of 48 cases and 42 ethnically matched controls included descriptive statistics. Overall, and in cases and controls, we looked at the medium, minimal, and maximal levels of cytokines and neurokines. We assessed levels of interleukin-1 beta, interleukin-1 RA, TNF-alpha, and IL-6 and IL-8. Our conclusion was compared with that of controlled women, whole blood from women with vulvodynia demonstrated an enhanced production of nerve growth factor, but not of a set of inflammation-related cytokines in response to Candida antigen stimulation. This study, recently published in 2019, the localized provoked vulvodynia association with nerve growth factor and transient receptor potential vanilloid type 1 gene polymorphisms. Their results suggest novel genetic susceptibility to primary LPV associated with specific alleles and genes TRPV1 and nerve growth factor, and propose the RS222747C allele of the TRPV1 as a common genetic predisposition for other pain syndromes. So I've talked to you about lots of research going on. This is a diagram of how it may all fit together with the interleukins, with the nerve growth factor, with the mast cells, the distal nerve sprouting, we haven't really come to the one answer for vulvodynia, probably because it isn't one condition. Let's move on to psychosocial factors. Davis et al. Published in 2015 a 2-year examination in cognitive and behavioral correlates for patients with provoked vestibulodynia and their outcomes. They found changes in both cognitive and behavioral variables were significantly associated with improved pain and sexual satisfaction outcomes. Finally, we'll end on the structural defects and vulvodynia. Here's a study published in 2015 that looked at the concepts of functional chronic pelvic and perineal pain. What was behind it? What's the pathophysiology? And is there a need for multidisciplinary management, which I'm fairly convinced there is. They found dysregulation of nociceptive messages derived from the pelvis and the perineum. When pelvic pain cannot be explained by an organ disease, this model can be used to propose personalized treatment options and also to identify patients who are high risk of postoperative pelvic pain, patients with multiple operations, central sensitization, post-traumatic stress disorder, etc. A very interesting article. I've alluded to this already, but I liked this study from 2016. Recent advances in understanding provoked vestibulodynia. I'm convinced it's not one disease, so it won't have one treatment. We can't forget the patient as we explore the etiologies of vulvodynia. They're not brains, they're not spinal cords, they're not vulvas. Each patient is a unique individual, and we need to remember that at all times. Thank you very much. Today I'll be talking to you about vulvodynia with an emphasis on medical management. I'm Hope Haefner. I'm from Ann Arbor, Michigan. I am an author on Up to Date. The learning objectives for this next 30-minute session. First, I'd like you to gain knowledge on the medical, the non-surgical treatments utilized for localized as well as generalized vulvodynia. I'll also show you ways to access detailed information for the medical management of vulvodynia. We have several extra handouts included in this lecture. Vulvodynia is a very expensive diagnosis. This was a study from 2012, and you can imagine with inflation that it's actually a much more costly diagnosis than is shown in this study. They estimated the national costs in the United States for vulvodynia range from $31 to $72 billion annually. We opened our Center for Vulvar Diseases in 1993. When we first opened it, we had a gynecologist and a sexual counselor. We now have gynecologists, sexual counselors, as well as family medicine physicians. This would be my ideal clinic. Many different multiple specialties involved, dependent on the diagnosis the patient you're seeing currently has. For example, it would be great to have a plastic surgeon involved in our clinic for some patients with nerve entrapment. Evaluating vulvodynia patients is a team approach. This is an algorithm that talks about how you examine the patient and then go on for treatment. I'd like to focus today on the treatment options. We'll start on vulvar care measures, go on to topical and oral medications, talk about some injections as well as physical therapy, cognitive behavioral therapy, and sexual counseling. If the patient doesn't get adequate relief from that, then you have to think about going on to some high dose as well as multiple medications for neuropathic pain. Also, you might consider referring this patient to a pain specialist who might give neuromodulation at times. So let's start with the vulvar care measures. First, we talk about no soap on the vulva. We talk about using shower heads for rinsing. A lot of my patients can't wear underwear, or sometimes they prefer boxer shorts to the tight underwear. Some of them wear a long skirt with no underwear. Many of my patients rinse their underwear twice or even more to get rid of any of the detergent. I'm showing you this picture. This is 100% white flannel that's cut into small pieces to use in the shower or after having a bowel movement. There's also on top of it a bag full of water wipes. They're 99.9% water and 0.1% fruit extract. Very unlikely to cause a contact dermatitis with either of these. By the way, I'd like to tell you that the cotton wipes that are purchased are not disposable in the toilet. You can get a solid white flannel bolt online, or you can also get it at a fabric store. Some of my patients use ice on their vulva, but I discourage it. I actually saw a patient that got gangrene from ice packs continuously being put on her vulva. This is what I recommend, and it's a cool gel pack. Vaginal lubricants are very important to our population with vulvar pain. Many of them prefer the silicone base. If they're using dilators in the shower, I recommend a water base so they don't slip and fall. And some patients with a lot of sensitivities will be recommended a hypoallergenic vaginal lubricant. This was a study by Dr. Witkin that looked at Vulvodynia drug research. He found if women with similar clinical diagnoses were all lumped together into a single group for a treatment trial, the outcome would be equivocal due to patient heterogeneity. Thus, subjects must be split into clearly defined groups based on probable etiology prior to starting a treatment trial. I'm going to focus now on Vulvodynia topical medicines. We have topical medicines that are compounded, used for pain as well as for muscle spasm. Let's first talk about the pain medications. The list on your left: amitriptyline 2%, baclofen 2% in a water washable base, gabapentin 5 to 10%, ketamine 5 to 10%, etc. And on your right are the muscle spasm agents, the diazepam vaginal suppositories with their starting dose and maximum increased, etc. The things I use most often on this list are starred, and the ones below it I have used but not as frequently. I suggest if you're going to be using these, you find a compounding pharmacist that you trust that will work together with you on these agents. Topical anesthetics such as 5% lidocaine are safe, and they can be effective, particularly when it's mild pain that's short-lived. One topical agent that I would recommend not allowing your patients to use is benzocaine. It can cause a contact dermatitis as well as rebound vasodilation and pain. Other compounded therapies that are out there, as well as therapies that are available in pharmacies, include some hormone treatments. We'll start with one in 2018, Imvexxy. This was FDA approved at that point in time for treatment of moderate to severe dyspareunia. In 2016, prasterone, DHEA, was approved for dyspareunia. Prior to that, Asphena was used, estriol, estradiol, progesterone, testosterone, etc. So let's start focusing on the first two. What about topical estrogens? A lot of people have concerns about estrogens with the Women's Health Initiative that came out years ago. However, a new prospective analysis from the Nurses' Health Study has shown that despite its black box warning, low-dose vaginal estrogen does not pose an increased risk of cardiovascular disease or cancer. This study, published in 2018, concluded that vaginal estrogen use was not associated with a higher risk of the CVDs or cancers, and it supported the safety of vaginal estrogen use and found it to be highly effective. Intrarosa or prasterone contains DHEA. This is a picture of a rose bush that was at an ACOG meeting years ago that I photographed. This was approved in 2016 and many patients are using it. What about oral medications? For patients that have generalized vulvodynia, particularly patients with moderate to severe vulvodynia or localized vulvodynia, we will use some oral medications. Tricyclic antidepressants have been used for years for neuropathic pain syndromes, such as postherpetic neuralgia, as well as vulvodynia. The doses that we use in these tricyclic antidepressants are lower than what is used for depression. The various antidepressants used for pain control include the tricyclic antidepressants, the SSRIs, and the SSNRIs. They can have some adverse effects, however. They can cause drowsiness. Amitriptyline tends to do that more than diazepamine. They can cause jitteriness. So diazepamine does that more than amitriptyline. Tachycardia can be involved. Dry mouth, dry eyes, increased appetite resulting in weight gain, and constipation are seen with these medications at times. The dosing, we recommend that patients start at a low dose. Generally, I'll start anywhere between 10 milligrams to 25 milligrams. However, at times I've gone as low as 5 milligrams as a start dose. I tell the patients to take it 2 hours before bedtime and not to exceed 150 milligrams nightly. They increase by 10 to 25 milligrams weekly, and they stay at the dose that their pain is controlled. We also ask them to call us prior to weaning it. We can go weaned dosing at 3-day intervals. However, we like to instruct them exactly on how to do that. We also tell them not to have more than 1 drink of alcohol per night. You should check for drug interactions. They do interact with many agents. If it's an elderly patient, you may want to consider a baseline EKG. You need to talk to the patient in detail why you're giving them a tricyclic antidepressant and let them know that it's not going to work after 1 pill, most likely not even after 1 week of pills. It can take up to a month to start working. Diazepamine is another tricyclic antidepressant. It's the least sedating of the tricyclics. The dosing is similar to that of the amitriptyline. And you can consider switching from amitriptyline to diazepamine if the patient is fatigued. This one is taken in the morning rather than at night like the amitriptyline. Patients should not get pregnant on these tricyclics. Venlafaxine XR is an SSNRI that we use at times. We start them at 37.5 milligrams and increase weekly up to a maximum of 225 milligrams. It's also used for diabetic neuropathy. This can take a long time to work also, up to 6 weeks. When tapering, we have them call our nurse to get instructions on the tapering pattern. Duloxetine has been used for vulvar pain. It's an SNRI. It comes in 20, 30, and 60 milligram capsules. We start the patients at 20 or 30 milligrams. The patient should not be on other SSRIs when it's started. If the patient is depressed, rather than a single dosing in the morning, you might consider instead splitting the dose to 30 milligrams POBID. Other medications out there, imipramine and milnacipran. So what about anticonvulsants? Anticonvulsants are often used for pain control. Many patients with neuropathic pain use these drugs. Gabapentin, pregabalin, topiramate, tiagabine, lamotrigine, and carbamazepine are all used. Our first line for anticonvulsants is gabapentin. We tend to start most patients at 300 milligrams. However, if a patient's very sensitive, we'll start at 100 milligrams. I've given you the dosing of all these drugs on your written handout. Topiramate I have found helpful for some patients. You have to be careful and not use it in a patient that has a history of kidney stones. One side effect of it is weight loss, and most patients don't complain about that. However, if you have a patient that is very thin, you're going to need to watch their weight closely. This study by Dr. Harris et al. Looked at gabapentin and found it helpful for generalized vulvodynia. 64% of 152 patients improved by 80% in a retrospective chart review. This study looked at a retrospective review of 28 women for vulvodynia that were using pregabalin. 12 reported improvement, averaging 62%. 10 patients discontinued it, however, due to adverse events, and 4 had no improvement. This was a paper that was against anticonvulsants as well as many other medications. This was published in 2016 by Dr. Goldstein. Their conclusion was that they recommend waiting for more empirical evidence before recommending alternative treatment options such as anti-inflammatory agents, hormonal agents, and anticonvulsant medications. This was a study published in 2018 that was against the use of gabapentin for the treatment of vulvodynia. It was a randomized controlled trial by Dr. Brown et al. Their conclusion was that extended-release gabapentin, compared to a placebo, did not reduce tampon test pain. These data did not support the recommendation of gabapentin alone as a treatment for vulvodynia. However, another study with similar co-authors was pro-gabapentin on sexual function in vulvodynia. This was a randomized placebo-controlled trial. They found that gabapentin improved sexual function in this group of women with provoked vulvodynia, although overall sexual function remained lower than women without the disorder. Another study looked at generalized unprovoked vulvodynia and the treatment with amitriptyline, gabapentin, or pregabalin. Their conclusion was that amitriptyline, gabapentin, and pregabalin produced long-lasting pain relief in most of the women with vulvodynia. However, we have to remember it's 2020 and the FDA continues to investigate potential misuse and abuse of gabapentinoids. They say that by some estimates, 2 in every 10 opioid abusers are also using gabapentin. Narcotics are rarely used, however, for vulvodynia. We're all familiar with the hydrocodone, the oxycodone, etc. We do not prescribe these for our patients with vulvodynia in our Center for Vulvar Diseases. This study was published in 2019. It was a systematic review and meta-analysis of the effects of treatment modalities for vestibulodynia. They looked at randomized controlled trials, and their conclusion was that several existing interventions were not associated with improvements in vestibulodynia. There only was improvement of sexual function with oral dizipramine with or without topical lidocaine. We found physical therapists to be very effective in treating our patient population with vulvodynia. Also, we found cognitive-based therapy to be very helpful. This study was published in 2019 entitled Mindfulness-Based Group Cognitive Behavior Therapy for Provoked Localized Vulvodynia. It was a randomized controlled trial. Their conclusions: mindfulness-based group cognitive behavior and education support group therapy were effective in reducing pain and distress. The women that had the cognitive behavioral therapy program showed greater improvement in certain secondary outcomes. This study, published in 2019, entitled A Comparison of Mindfulness-Based Cognitive Therapy versus Cognitive Behavior Therapy for the Treatment of Provoked Vestibulodynia in a Hospital Clinic Setting, concluded that integrating 8-session group mindfulness therapy programs into the clinical management of provoked vestibulodynia was effective, was feasible, and was satisfying to patients. Another study, more recent in 2020, entitled Mindfulness and Cognitive Behavior Therapy for Provoked Vestibulodynia, Mediators of Treatment Outcome and Long-Term Effects, concluded that both mindfulness behavioral cognitive therapy and cognitive behavioral therapy were effective for improving symptoms in women with provoked vulvodynia when assessed 12 months later. Their findings had implications for understanding common and potentially distinct pathways by which CBT and MBCT improve pain, as well as sex-related distress in women with provoked vulvodynia. At times, trigger point injections are given for pain, particularly when it's a small area, localized pain. Bupivacaine mixed with triamcinolone can be given in a small area. I'll use 0.5% bupivacaine. If I'm injecting a large area, I'll use 0.25% bupivacaine. You can give up to 40 milligrams of triamcinolone over the entire vulva, but for point tenderness injections, I'll use 5 to 10 milligrams. These can be repeated monthly and have around about a 50% efficacy rate. Sometimes we'll do pudendal nerve blocks, other times we'll do generofemoral ilioinguinal nerve blocks. If a ganglion impar block is needed, we'll refer them to our pain clinic for that. The pudendal nerve originates from S2, S3, and S4. This diagram shows a maize and blue vulva out there for you Michigan fans. The blue area is the pudendal nerve distribution, and you'll see in this traditional photo, it is felt that the clitoris is supplied by the pudendal nerve. However, I think there is some overlap in the yellow area to the clitoris. The yellow area is the general femoral and ilioinguinal nerve area. So if someone has clitoridynia, our first line is to do a block of the general femoral ilioinguinal nerve in clinic. We do a bilateral nerve block, and that often helps with the clitoridynia. We'll inject bupivacaine and triamcinolone into each side to hit where the general femoral and ilioinguinal nerves overlap. Interventional pain management is important for all different types of pain, but can also be helpful for vulvodynia. Both radiofrequency nerve blockade and spinal cord stimulation have been used in pain management. A study published in 2018 entitled The Treatment of Chronic Refractory Neuropathic Pelvic Pain with High-Frequency Spinal Cord Stimulation was published. When I pulled the article, however, only one of the patients was female. But when you read through the article, you think that it may be applicable to vulvodynia. Sacral neuromodulation is also used for chronic pain conditions. Neuromodulation may be used for the sacral nerve as a sacral nerve stimulator. It's good for refractory pain in the distribution of S3 and S4, as in this patient. TENS units have also been used for vulvar pain. Intravaginal or subcutaneous vulvar peripheral nerve stimulation has been found to be helpful for this patient population. This study looked at transcranial electrical stimulation, or peripheral nerve stimulation. They had 40 patients, 20 received treatment and 20 received sham treatment. Interestingly, both groups improved slightly. However, the treatment was not superior to the placebo, and it was not statistically significant. This study by Marina et al., entitled Vaginal Diazepam plus Transcutaneous Electrical Nerve Stimulation to Treat Vulvodynia. It was a randomized controlled trial. They had 42 patients who were randomized. 21 underwent diazepam and TENS unit treatment, and 21 received placebo and TENS unit treatment. Their findings were that the diazepam plus the TENS unit was useful to improve pain and instability in women with vulvodynia. Finally, there's the impar ganglion sympathetic block. This is used by interventional pain specialists at times. The ganglion block is visualized, and as you can see on your right side, a needle going into the spinal canal. What about botulinum toxin? Botox is used for vulvodynia. We give it in our Center for Vulvar Diseases in our sedation clinic. We give generally 100 to 200 international units at a time of injection.
Here are some recent articles on botulinum toxin. The first was entitled Subcutaneous Botulinum Toxin Type A Injections for Provoked Vulvodynia. It was a randomized placebo-controlled trial and exploratory sub-analysis. Another article looked at the methodological approaches to Botox for the treatment of chronic pelvic pain, vaginismus, and vulvar pain disorders. Yet another article looked at Botox for the treatment of localized provoked vulvodynia that was refractory to conventional treatment. This next article explored the non-neuronal and non-muscular effects of botulinum toxin. It was an opportunity for a deadly molecule to treat disease in the skin and beyond. And the final article was entitled Therapeutic Approaches of Botulinum Toxin in Gynecology.
Acupuncture is out there. I've pulled the most recent literature. One study by Schläger et al. Did 10 30-minute treatments over 5 weeks. They used the McGill Pain Questionnaire and the FSFI questionnaire. Results, however, were not statistically significant. And I actually haven't found an acupuncturist in our area that knows the anatomy enough to treat this patient population. This was another study published on acupuncture, the effectiveness of 2 different acupuncture strategies in patients with vulvodynia. However, when I polled it, it really wasn't a paper. It was just the study protocol that they were going to use for a pilot study. And the final acupuncture study I'm going to review is one published in 2019. Dr. Leclerc is also on this article. It was entitled Acupuncture Augmentation of Lidocaine for Provoked Localized Vulvodynia. It was a feasibility and acceptability study. Their objective was to assess the feasibility and acceptability of acupuncture's augmentation of lidocaine therapy in the treatment of provoked localized vulvodynia. Their conclusions were that early phase research findings were that acupuncture augmentation of lidocaine was acceptable. There is hypnosis. There aren't any great studies on it for vulvodynia. However, there's some case reports out there for vulvodynia and hypnosis. Many other treatments are around for vulvodynia. However, a lot of them are short-lived. This is a long list of things that have been used. Some still remain, but many of them are no longer used.
The 2013 Vulvodynia Guideline Update, published in the Journal of Lower Genital Tract Disease in 2014 by Dr. Stockdale and Dr. Lawson, is an excellent review on vulvodynia treatments.
The American College of Obstetricians and Gynecologists has a committee opinion published in September of 2016 on persistent vulvar pain. The NIH has had several vulvodynia awareness campaigns where research is analyzed and new research ideas are obtained. The National Vulvodynia Association has excellent patient education regarding the nature of vulvodynia along with treatments. I've given you oceans of lotions, potions, and notions for vulvodynia. I think after hearing this lecture, you'll realize it's not one disease, thus there's not one simple cure. The extra virgin olive oil won't cure all vulvodynia patients, nor will the oral medications, nor will the white cotton underwear, nor will the physical therapy or surgery. We can't forget the patient as we're caring for them. They're not brains, they're not spinal cords, and they're not vulvas. They're people, and we have to think of them as human beings that need our help at all times. Any additional information you'd like on vulvar diseases can be reached at this website. You can scan in this QR code at the bottom right. All right, well, I appreciate everybody listening to this. I've been trying to answer questions as we went through. A couple of announcements before I answer any more. I wanted to mention that the ISSVD is having an upcoming meeting in the near future. It will be in July in Ireland. We'd love to see you all there. Debbie, can you hear me?
I can.
Okay, great. The second announcement, I think some of you may have seen when I was typing some things. There is another meeting I'd love to get international attention to. I'm running a meeting along with the help of Debbie Ropey, actually, with the Childhood Ovarian Cancer Association. We're going to have a meeting in Ann Arbor, Michigan, but it'll be via Zoom so that international people can attend. Please type in childhoodovariancancer.org for additional information if you're interested. I wanted to mention on the website, Debbie's going to go ahead or somehow get you a lot of information from today's lecture. You're welcome to look at the slides, the PowerPoint, but I've also gotten together all the recipes for these drugs and also gotten together more recent references between 2020 and 2022 that I just updated for your interest. If you are interested in getting more information, you can go to our website. You just Google vulvar diseases provider information, or hopefully you'll have gotten a QR code to scan in. So now I will do my best to get to any other questions. Do we have time for that, Debbie?
Yes, but just give me a minute to thank you so much. Hope, I know everybody is super excited to have heard you today, and we've had a record number of people joining us. So I know that is because everyone knows what a great speaker and lecturer you are and how much you know on vulvar disease. I did want to let you know that a lot of people have been asking if this will be available later. And yes, this is part of our Essential series that we've started to give you some basic information leading up to the World Congress, where of course you'll get even more updated information. But this will all be available on our website on the Vulvar Awareness campaign page, which we are in the process of updating. And of course, we'll add all this information. We'll include Hope's QR code so that you can get her recipes, as well as we will give you the handout or the copy of the slides that lots of people have been asking for. So I know everybody wants to get these questions answered. So Hope, if it's okay with you, I'll just go through the questions that are still here.
Okay, are you going to read them then?
Yes, Dr.
Perfect.
Jenna Benyons, I'm sorry if I said your name wrong, says that she has a handful of clients who have acquired genital neuroproliferative disorder. She's tried to treat them with amitriptyline, baclofen, gabapentin, and then moved to cyclobenzaprine, lidocaine, ketamine, amitriptyline in an ointment base. Many of them are not getting better and complain of worsening and itching after trying the second ointment.
Well, I think it all depends on exactly where the neuroproliferative disorder is affected. For example, if you're having it localized to the vestibule and you've tried all those things, I think it's time to consider the Botox or consider a vestibulectomy with vaginal advancement. There was a study done by Kermit Krantz in 1958 where he actually looked at vestibules in comparison to vagina and compared the number of nerve fibers. And the truth is the vagina has very few nerve fibers compared to the vestibule. So if you cut off the vestibule and then bring the vagina down to cover it, that often is what it takes to take care of the pain.
Okay. And then Camila Carvalho said that wanted to ask you if vestibulodynia, which I think she might mean vestibulodynia, is that a type of vulvodynia? And could you tell us a little bit more about the classification?
There are two subcategories of vulvodynia. One is generalized and one is localized. And vestibulodynia means it's localized to the vestibule. The only other two types of localized are clitoridynia, or if you have a vertical entire half of the vulva, it's called localized also.
Great, thank you for that. Does glutamate have any role in this condition?
Not in my experience without doing a recent literature search on glutamate. That often makes me wonder if you've noticed that, and unfortunately, we're not able to have the audience speak up right like I usually do when we're in person. I suspect you've seen something with that, but it hasn't been anything that's caught my eye.
Great. Well, hopefully they'll come to Dublin and we can talk there.
Yes.
Dr. Duval is asking, what is the dose of Botox and the time interval between applications, and for how long can it be used?
So the dose of Botox varies depending on the studies. There were actually some studies from the Netherlands where they were using 45 or less international units and didn't find that it worked. However, the studies that have used 100 international units, and some even go up to 200 international units, do get some decent relief. Almost everything we look at with vulvodynia and the percent that get improved is around 65% of the patients get improved with no matter what treatment you do, even sometimes if you just do a placebo. So I have gone where I start with 100 international units, and then if that doesn't work and I repeat it, I'll go up to 150 to 200 international units. I try to go 4 to 6 months out. One of the reasons so far out is that it's very, very costly here in the United States for one vial. So that's 100 international units. That is $1,000. And that's not even counting if you're having to do it in a sedation clinic. Those expensive then are even higher.
Wow. That's exactly why I'm not using it. Another person is asking, does vestibulectomy have good results?
When you look at the literature, you find results of success 60% to 90%. When I actually pulled all the literature when I was writing a paper several years ago, I found out that the people that had the 90% success rate were operating on patients immediately. Some hadn't even had vulvar pain more than a few weeks, and that doesn't even qualify as a diagnosis of vestibulodynia. So I say that our success rate's probably towards the 65, 70% because we do everything first. Topicals, orals, physical therapy, often Botox before we operate. And then we operate then on the ones that are the hardest to treat because they've been the most resistant. Also, I think you need to address the vestibulodynia and vaginismus. If your patient has vaginismus, try to get that fixed with dilators, sexual counseling, et cetera, Botox, et cetera, before you do the vestibulectomy. If you have pain up by the urethra at the 1 o'clock, 11 o'clock positions, we do bilateral V to Y flaps, because if you do a vestibulectomy and just close the vagina at all those areas, it gets way too tight.
Great. And I know we've had other lectures where you've been able to have more time to go into that. We've got a question from Edith Carpio. What is your experience with topical gabapentin and how do you use it?
I use quite a bit of topical gabapentin. If you look in the literature, they say 2% to 6%, but I almost always go with 6%. Minimal absorption, minimal side effects. My favorite is 2% amitriptyline, 2% 2% amitriptyline, 2% baclofen, 6% gabapentin in a water washable base. You start at it nightly with a gradual increase. Sometimes you can go up to 3 times a day, but after that, it's a hassle to be putting something on the vulva more than 3 times a day.
Okay, great. And just a reminder, we'll get you that QR code again so that you can download some of these recipes from Dr. Haefner. Any recommendations, Dr. Haefner, for cannabis-infused lubricants for intercourse?
Ann Arbor, Michigan is one of the big cannabis places. They have about 15 places you can go and buy it. I am not that convinced that topical cannabis is the answer. However, more studies need to be done on it. I do think some of the oral cannabis may be good because people are using that for chronic pain syndromes and getting good results. And for those of you that are interested, they make a THCA and a CBD in pills. So you can take 2 separate pills. THCA is one pill, CBD is another. And you don't get high on that if you don't want to get high, because a lot of people actually don't want the side effects of the marijuana being stoned. They just want the pain relief.
Okay, great. I believe that answered this same question, but just to confirm, is there any clinical or anecdotal evidence for the use of vaginal CBD THC products for vulvodynia? I think you answered it, but.
No great studies. There was one, no great randomized controlled studies, which is the story of everything in vulvodynia almost, right? And
Right.
vulvar disease, right? But there was a presentation done at the last World Congress that I thought was very interesting. And one of our faculty here at Michigan looked not at the treatment with CBD, but what percentage of our patients with vulvodynia and other vulvar conditions actually used marijuana. And it's definitely being used across the world much more frequently than it was in the past.
So if someone wants to join and do a study, we would love to hear it at one of our congresses.
Double-blind, placebo-controlled, randomized.
Exactly. How about laser therapy for vulvodynia?
Well, we just had a debate on that topic at a recent ASCCP meeting, and it was a very interesting debate. I thought it would be a quick, easy topic to get ready because it was going to be a 25-minute debate. So that meant I would have half that time and another person would have half that time. Well, I can't tell you the number of hours it took me to get that lecture ready. There were over 225 articles on this.
Wow.
And by the end, I happened to be assigned con, laser rejuvenation. The other person was pro. And by the end, I think we were actually meeting in the middle.
Interesting. Yeah, we're also going to have some discussions about that at the upcoming meeting in Dublin. So we've got another question about how soon can a patient expect to see improvement from the 3-component, which is amitriptyline, baclofen, and gabapentin topical treatment, and how long should a patient use that regimen?
So it's going to take a couple weeks to really kick in, if it's going to kick in. I used to say with the oral antidepressants, a month or so. You can use any of these agents long-term. Topical, you can use for life. The only problem in the US, it's somewhat expensive to get a compounding medication, whereas oral amitriptyline is very inexpensive. But you can use any of those long-term. I had a patient that was on 20 years of amitriptyline.
Okay. A couple questions about Botox here. What muscles are you injecting it into? Do you dilute it 1-to-1? And is there anywhere that you know that people can get training for that?
So I injected into the bulbar cavernosus and the levator ani. I probably do 10 at least injections. I have a TB syringe that I fill. I think rather than going into the dosing, I will go ahead and send that to Debbie so that it's 100% easy to read and you have it just the way to dilute it. You want to let the saline go in gradually. Lynn Margison taught me that she would actually take the rubber off the tube of the Botox and then let it go in through a TB syringe. A lot of people, though, just put it in a needle and then let the needle draw it in itself. But I will send that to you, Debbie.
Okay, great. And I'll include that. We've got everybody's email that joined us today. We've got 3 questions left. If you can hang with us just a little longer, and then we've got just a quick promotional video to give you that discount code and some other information. Someone is asking about a procedure that they do in Britain called the Defentins procedure. And she wants to know if that's just a fancy way of saying vestibulectomy, if you're familiar with that.
I am not familiar with that procedure.
Okay. How about hydrotherapy for vulvodynia?
It's out there, it's in the literature, just like everything we've talked about. Not a lot of good randomized controlled trials.
Need more actual studies. Okay, great. This is a great question to end it with, I think, is what do you think is the most important for the future of vulvodynia research, and which upcoming vulvodynia treatments are you most excited and optimistic about?
Well, first of all, I think to get the right treatment, we need to get better with research at categorizing the different forms of vulvodynia. It is not one disease. And once we can categorize the different forms, then we can figure out, based on that form of vulvodynia, what the right treatment is. So there will never be one treatment. For localized vulvodynia, we can do surgery, and the majority of time that's going to help. But for generalized, it's not going to be one treatment. And even localized isn't one disease. We have people that have point tenderness where a bupivacaine steroid injection is going to take care of that pain. Whereas people with the entire vestibule that has been present with pain for 35 years, unable to have intercourse, I'm not sure a vestibulectomy is going to be their cure. It's not the same disease in every patient.
Exactly. Well, once again, I really, really want to thank Dr. Hope Haefner. She obviously is an enormously interesting speaker. She's done so much for the world of vulvovaginal disease. If you do have interest in childhood ovarian cancer, do check out her other course that she has coming up in June. We would like to start just a short promotional video here to give you that discount that we promised you. Thank you again, and hope to see you in Dublin. Gia Hoyt. Hello, my name is Debbie Ropey, and I am the Executive Director for the International Society for the Study of Vulvovaginal Disease. I am hoping that you are going to join us live in Dublin, Ireland, for the 26th World Congress and International Vulvovaginal Disease Update, which is being held at the beautiful and prestigious Trinity College in the heart of Dublin, Ireland. The World Congress is going to be held from Monday through Wednesday on July 18th through 20th. Now, prior to the World Congress, we're going to have our International Vulvovaginal Disease Update. We're hoping that you'll take this opportunity to join us for this live event and our first time back to being able to shake hands, network, and join each other in social events. I also want to promise you that we will make every effort to make this event safe. We are also going to be offering live streaming. And even on top of that, we are going to have an enduring platform, which you will be able to go back and watch any of the presentations a second time or any that you possibly miss. And the best part is you can register now and change your mind later. So go ahead and register either for live or virtual, and just know that you can change your mind. We hope that will make you feel safe registering. And if you register early, you will get the very best price, I promise you. So it's a great opportunity to come and learn everything that you've always wanted to know about vulvovaginal disease. Hope to see you in Dublin.